Shiva Karanya.
I'm Kelly Grimes.
We're part of the communications committee here at SOSORT, and we're very excited you're here to learn from your wisdom, and we're very happy you're taking some time to answer some of our questions. So I read that you originally wanted to be a lawyer. What made you change your mind?
Well, I've always been interested in government and the world in which we live, and always wanted to make it a little better place. And somehow I thought that if I went to law school, I could become a politician and I could, help the world. But then I realized that there are other ways, and even though I'm still interested in politics and history, I felt that with a suggestion from my mother, did you ever consider medicine? And I said no, and I went down and visited with our family physician and learned about what he did and the impact that a physician could make. And I decided that I could do that in a more realistic way than necessarily doing it in a much larger national scale in politics. So I decided to become a doctor.
I think it's so great after listening to your talk that you're kind of implementing some of law and policies into your passion, and it's definitely making a difference. I know at Columbia University we talk a lot about quality, and a lot of the doctors there are also trying to work towards doing less fusions and making them more efficient, and really trying to implement more non-op techniques.
Yeah, I think also, on a bigger scale too, one thing you learn in life is that if you're not at the table, you have absolutely no impact on anything. You can talk about it till you're blue in the face, but unless you're actually sitting at the table with people who make decisions and who can implement things, then you have no chance of making a difference. So in the quality and safety movement, which I know you're interested in Columbia, it's important also to have a voice. It's beyond that, so that you can have a broader impact.
Great. For you, looking at your grand body of publications, for you, what is your most meaningful body of work that you've published?
Well, I think it's kind of looking at the world of spinal deformity. I think, I became quite interested in that when I was a resident and when I was a young faculty, because no one in Iowa was treating scoliosis at all. So we have a 3 million population base with no comprehensive care program, and I was kind of tasked to start that. And as I mentioned yesterday in my presentation, the education which I had, the foundation of which is knowing the pathoanatomy of disease and understanding natural history. When I finished my training, it was unclear what the natural history was because there were two conflicting schools. One was it was a terrible disease and everyone needed to be treated. And the other school was that, people do have normal lives even in the absence of treatment. And to me, it was important for patients and their families to be able to ascertain, what is a natural history. So that was the first. And then all along the way, trying to help patients make decisions and asking the question, do treatments really work? Yes, I'm a surgeon, I do a lot of surgery, but if there are treatments which can prevent patients from having the need for surgery, we need to develop those and find out what actually does work and make sure that patients have access to those treatments.
I know a lot of work still needs to be done on giving effective care for spinal deformity. What are your thoughts on dosing, on bracing specific? And we discussed if the study had actually went all the way to completion, how much more we could have learned. What are your thoughts?
Well, I think in the aggregate, the study showed that if you wore the brace more than 13 hours, it was the same as 13. So if you wore it 16 or whatever, but that's the aggregate data. What we think is going to be the case is that every patient will need a different bracing dose. And that hopefully in the next years to come, we'll be able to give a specific prescription. Number one, we'll be able to get the number needed to treat lower. Right now it's 3, and we'd like to get that to 1, and then be able to give a specific prescription for that patient to exactly how much bracing do they actually need and for how long. So that's, I think, the ultimate goal.
On your presentation yesterday, there was an equation that you could plug in. Is that already available for anyone to use?
It will be out shortly in spinal deformity, and this is a scoliosis risk calculator based on the brace data and other data, which will give clinicians the opportunity to plug in their patient's maturity, be it by the Sanders maturity score, the Risser scale, the curve type, etc., and be able to give them a specific risk of failure, in other words, getting to a 45 or greater degree curve. And then also the calculator will have in it, for example, the hours of bracing. And it's hoped that this will get widespread usage and people could put it to use in their practice and actually refine it and make it better. But it should be coming out of spinal deformity,
So cool.
hopefully soon. Yeah,
Very
it's really exciting.
Yeah. What are your thoughts on brace heating? I've asked this question to so many clinicians and physicians, and right now we just don't have an answer. I know we talked about it at the consensus meeting as well.
Yeah, that's a tough question. I think in the brace study, our criteria for ending was when the patient had a digital skeletal age of 7, and we just stopped the brace completely. In my practice, though, I must admit I always feel that there is some unquantifiable amount of growth still remaining, and that if in my own practice I actually have the patients wear it at night through high school and then can abandon it. But I also tell them that there's no scientific knowledge to support that, and it's just my feeling about it, which isn't really very good, but I and most of them actually do it. They feel quite comfortable sleeping in it, and it makes me feel, at least, especially for boys too, that they will be having some active treatment during whatever growth might remain. But I think it's an unanswered question.
So we had the privilege of attending your grand rounds when you came to Columbia, and just had a chance to hear about all the impressive work you've accomplished. What is your next big area? Does it seem like it's going to be policy, looking at the bigger picture of healthcare costs? Is it looking at a different aspect of spinal deformity?
Well, I think I want to continue the work we're doing on non-surgical management. Again, even though I'm a surgeon, my main focus is non-operative management. So I would really like to get the number needed to treat down further, because I realize in my lifetime using the old criteria which we used to use for bracing, Risser less than 2, Menzies less than a year, I braced way too many patients. And also, now that we have the EOS, you know, when you can actually see the iliac crest in a different way, you see how many patients that on the AP view look like they're Risser 1, but actually they're much more mature. And having more of these maturity markers to follow, I would like to make sure that we only treat patients who really need treatment, who are at high risk. So that's one focus. And I still think this bigger picture, I think for me personally, and I hope more clinicians and in all disciplines will become much more active on the political front. It's not in healthcare workers' makeup to be politically active, but having spent, as I mentioned this afternoon, so many years, a week a month in Washington, D.C., if you are not there, your voice will never be heard, and you need to have a cadre of people in every discipline, hopefully working together, not at cross purposes, but together in the interests of patients. Then you can make a difference in healthcare policy, because I feel in this country we are in such dire straits with the costs of healthcare that if we don't do it, decisions will be imposed upon us by people who really don't take care of patients. They don't understand what it means to be in a face-to-face confrontation and discussion of issues and what costs really mean. And so I just feel I need to be at the table, and not just me, but actually a whole cadre of interested individuals. I just don't want bad things to happen based on poor information.
Absolutely. As PTs, I think we are very, very lucky that we live in an area that has a lot of access. Sometimes the frustration and the hard part is that there's too much access, at least where we live. What advice would you give to professionals who live in areas where there is little access to get buy-in from the medical community?
I think that's a really difficult problem because I live in rural America, and for example, we had only one Schroth therapist in Iowa, now we have a second, but the geographic distances for patients are great, and how do you make non-operative treatment work in rural America? You know, if you're having an operation, fine, you go to the hospital, you get the operation and so on, but if you're in an active bracing program, if you're doing a therapy program, etc., and you don't have people right in your community, it is very difficult. So I think that's a real challenge, and societies like SOSORT could contribute to that, because delivering non-surgical care where it's not available or it's limited is a real challenge. And you know, how do we use telemedicine? How do we use the internet to have group therapy sessions and things like that, and how do we keep people connected? It's very easy. You live in New York City and you've got 50 Schroth therapists, and everybody can go down the block for a session, whereas my patients come from 6 or 7 hours away, and it's very difficult. So I think those are real challenges.
Yeah. What advice would you give to like a newly trained scoliosis PT in an area that doesn't have much support from physicians? How to reach out to a physician? Just talk about non-operative options.
I think that's a really difficult thing to do, but I think you need to shop around and find someone who you can actually sit down with, have a conversation, and develop a relationship so that you can look at things together. And as I alluded to my talk this afternoon, it's not a physician-centric world anymore. The new paradigm is patient-centric, and patients deserve to have all the resources of all disciplines brought together. So I think a new therapist in a region needs to seek out and build a relationship and find a willing partner. And I think that will happen more and more and more as younger practitioners who realize that is the way of life, as opposed to the more senior generation who's used to controlling everything in the doctor-patient relationship. But I think the new generation of physicians realizes that this is a different world, and they really need to avail themselves of all resources that could help their patient.
Dr. Weinstein, one thing I've always appreciated each time I've heard you speak is that you're always really keenly aware, as you said today and in previous talks, about the patient experience and really the patient psyche and the psychosocial aspects of the patient experience. How do you feel like we can do a better job in the hecticness of day-to-day clinical practice of bringing that a bit more to the forefront?
Yeah, I think if it's one thing if you're dealing with an infantile scoliosis or early onset and all they want to do is, play with their iPad. Yeah. But when you're talking about the adolescent group, it's very different, because you need to enfranchise that patient, as you heard Luke or someone say today. My interaction is never with the parents, it's always with the patient. And, if they don't want to, if they appear to be disinterested, I know they're listening. And I need to have them feel that this is their life, and I'm not going to tell them anything that they have to do. This is their decision, and they need to discuss it with mom and dad or whatever the family situation is. And so I think those communication skills are things that, I think if you want to go into healthcare, you should have communication skills. Otherwise, you would go into a discipline where you don't contact patients. But if you really love what you do and you want to have patient interactions, you need to learn how to communicate. And hopefully you're a good communicator to start with, but that isn't the case in many circumstances. And also, because of these reimbursement issues, healthcare providers are often forced to get through many more visits and shorten the time with the patient. But I think if you shorten the time with the patient, you shortchange that patient, and also you miss an opportunity, because I think the better your healthcare provider patient interactions are, the more people are going to want to have those interactions with you. But I just totally think that physicians dealing with children need to be communicating with the child and empower that child, even though it's very hard for them to be empowered. Depends on their family dynamics.
Mm-hmm.
But at least my philosophy is always I've got to give them that opportunity and let them know that I'm on their side, and this is you and me, and mom and dad are over here. So I feel really strongly about it. I can't tell you how much I actually love spending time with my patients, because they give me hope for the future of this country. They're so excited, energetic, enthusiastic, and they deserve to have control of their lives, particularly the teenagers.
Absolutely. Yeah. So in light of your talk today, with the image of the patient in the pilot seat and the rest of the parties co-piloting, it's almost as if you frame the entire interaction around the patient in the driver's seat or the pilot seat, and everybody else kind of co-piloting and
well,
guiding the
I
process.
sincerely believe that too,
Yeah,
and it's like, I hear stories all the time that people go to a quote orthopedic surgeon, and if you don't need surgery, they're really not interested in you. And that's the perverse incentive system we have, which I mentioned today. You get paid for services, you don't get paid for not operating. And the fact is that has to change. You have to be focused totally on the patient. And when I visit third world or developing countries and I see patients come in and they're just told, you need this, you need that, there's no discussion. And that I would say was America 30 years ago. You came in, the doctor told you what you need, and you didn't really question their authority. And I think the world has changed with social media, the information on the internet, which is sometimes not very good, but it's a different world. And again, I think this is in your generation going forward. You will always be in charge of your health care, and you should be. And you should have choices, and people should be giving you the information so that you can make a rational choice that fits your values. And as I mentioned yesterday, nobody with adolescent idiopathic scoliosis has to have surgery. That's a choice. You have to weigh the information, the pros and cons, risks, benefits, and then you can decide if that's what you think you need.
Makes a lot of sense. On one other topic, I've been struck by how well you, your mentors, your institution have valued and really been so meticulous about such systematic record keeping. I think so many of us aspire to that. We think we have good clinical outcomes, but then when it comes to what kind of records we've produced and how that process has come about, I'm pretty fascinated by processes. I would imagine that's a pretty intentional, day-to-day or constantly evolving process.
Yeah, it is, but I have to give credit to the person who started our department, founded our department, Arthur Steimler, who was a brilliant man who was trained in Vienna. He's from the old Austria-Hungarian Empire, trained in Vienna, and then came to the United States. And he was a meticulous record keeper, and I'm the beneficiary that his student was Ignacio Poncetti, who was my mentor and colleague for 37 years. And the tradition of our department is to maintain records and keep in contact with the patients. And so I wouldn't say that I certainly am the beneficiary of all that, but I think it's important to us because nothing destroys confidence like follow-up. And you need to basically continue to follow your patients your whole life, because you if you work in a children's hospital, let's say, where the age limit and the cutoff is, let's say, 18 or 22, you never see what happens to your patients when they're 40, 50, and 60. And I'm so lucky that I've had the opportunity not only to see and examine these untreated patients, but also now to follow my own patients for 42 years and know how they're doing and feel even more confident about some of my decisions and less confident about others. And so it doesn't have to be an academic medical center. I think you can do this in private practice as well, but you need to establish a good record keeping system. You need to keep in contact with your patients, and you need to have a bargain with them that we're going to learn and we're going to go through this journey together. And, our relationship doesn't end, in my case, when you graduate high school or go to college. It's your whole life. I want to see you. I want to know how you're doing. I want you to feel free to call me, and I'm going to feel free to call you too to see how you're doing.
Thank you for bringing that up. I've been curious about that, wondering if the patients that you followed for the study, you also do that in your clinical practice.
Yeah, I had an interesting situation last week, actually. A young lady came to see me who I had operated on like 37 years ago, and she's a lawyer in Salem, Oregon, and she asked me, do I have to come back again? Because usually I schedule every patient for a 5 to 7 year return. And she finally says, I've got 2 kids and I'm doing great, and I'm a lawyer.
Yeah.
Can you let me off the hook?
I promise I'm ready to graduate.
So, but those are the rewarding things about staying in one location your whole life and having that kind of relationship with your patients.
Love it.
Well, thank you so
That's great.
much.
Thank
for
you.
your
Yeah.
time.
Thanks so much. I
Appreciate it.
appreciate the opportunity.